So I'd like to take this opportunity to thank the organizer for inviting me to share some of our experience, particularly in the physician perspective in the health technology and diffusion of technology into healthcare to patients. And these are my disclosure. Most of my funding are from the government, AFP Innovation Fund, some of the Opportunity Fund, and I sit on some government committees, so no research or any funding for industry conflict. So this morning we're tasked with the panel to talk about some of this physician and industry uptake into the strategy into the institution and patient. I'm going to tailor about 20 minutes or so to review with you about innovation, the role of the health technology assessment, and about the knowledge translation aspect. We're going to talk about some of the barrier, why physician in some of the knowledge translation path to patient, where are the barriers that we see facing day in and day out in acute care setting. And also we're going to discuss some of the strategy, how we can go around and get some of this collaboration as we have talked about in all these panels. You talk about medical innovation and technology. This is a very fast pacing. In the last decade, we see much faster pace in both the technology side and also in medical science. And if you really want to ask is what is innovation, everywhere you go, they're going to say innovation. Is it really, you talk about a new way of doing something, or actually it's a way of doing something totally new? So it must be substantially different. Our Health Canada definition, however, those is an innovation and is represent of an effective treatment of prevention or diagnosis of a disease or condition for which no drugs or medical device is currently licensed in Canada. Now you look at some of this advancement in technology. This is back in 46. This is the space about 1,800 square foot to host a computer, a mainframe computer. And you can see with the Moore law that back in 1970, all the way until the current 20th century, you can see the pace of the computer at the advancement in technology that help in propelling the knowledge. So trace back some of the monument statements, sometimes the reminder that's been quoted back in 1977, not too far away, only about 3 decades away. There's no reason anyone would want a computer in their home. This is, 20 years ago. Computer in the future may weigh no more than 1.5 tons. This is 1950, not 49. I think there is a world market, maybe 5 computers for a world market, and that's from the IBM. So that's. You really see what we have here now. This is the microchips. This is an ant holding a microchips in his jaw, in his mandible. And if you look at the electron microscope of a silicon microchips, this is how the current technology and advancement. And the nanoscale for nanotechnology and nanomedicine in the field that talk about innovation is fascinating in the world, both in the surgical world, in the medical world, and the therapeutic world. Respectively, you look at the scale of the Earth, which is scaled down about 10 million scale smaller, give you a football. And the nanoscale, you look at a football, a nanoscale is about 1 billion times smaller. So this is this magnitude. So you look at the application for nanotechnology nowadays, massive for technology advancement and innovation per se. Particularly medicine, you can see here that for cancer treatment, active research ongoing, bone treatments, therapeutic treatment, and also drug development, cancer drugs, the active drug therapy, medical tool, diagnostic tool, and imaging, tremendous advancement for innovation. So with all this technology that come with a cost, healthcare is indeed a very, very expensive for any country in the world. You can see here, US always outpace, which is not, should be proud of, outpacing the rest of the world in regarding 16% of their GDP into healthcare. And we all heard about our Ontario and our Honorable Deb Matthews saying the Excellent Care Act for All, basically strengthening our focus not only for technology, it's quality, the value that we invest, as well as the evidence base that we're going to best practice to our patient. And the whole key aspect is accountability at all levels. So we talk about health technology assessment. Health technology by itself broadly can be defined not just the technology or device. It's broadly defined as the drugs, also the device, and medical and surgical procedure as well, and the measure for preventing and rehabilitation of the disease, and the organizational structure to support the system in which the healthcare is being provided. And you talk about the health technology assessment. That's basically what we try to seek to do is to inform health policy, develop health sound policy by which you can use scientific evidence, best practice on the medical, look at the social side, economic side, and the ethical implication for the investment for our healthcare dollar. If you look at the regulatory level in Canada, in our own country, it was regulated by the Health Canada. The program is the medical device program. It monitor, evaluate the safety, efficacy, and the quality of the diagnostic and therapeutic medical device, so that the consumer or the public and the healthcare profession can use them with confidence as a regulatory body, like the FDA back in the US. This is a little bit of busy slide. Courtesy from Dr. Janet Martin, who run the program in our department and the London Health Science as well for the HTA and the EPIC core for the peri-op outcome. You look at the Health Canada, the drugs and the device license for market. These are part of the so-called this coordination in our system. You look at some of those device, forget about drug for the time being. This morning we are not talking about drugs. The device and the machine and the procedures, they all gone through Health Canada. Take, for example, the medical device program. They all came down, and some of those diffused down in Ontario. Take, for example, we have OTEC, and now being incorporated maybe in the future into the Quality Council for the pre-market and post-market as well. So you look at all of this come down in Ontario, and this is not binding though. If you look at the mandate that has been being developed of the assessment, and they got diffused to the hospital or uptake or not. Also, the hospital or the clinician group or the physician group can also get access to all these other assessments from the government as well, can get access to those. But none of these are binding, i.e. majority of decision making is locally at your institution, at your physician group, at your specialty. If it is a surgical technology, medical device, or a technique or a therapeutic agents. For the drug, it's a totally different pathway. They have the Cardiff and then the Ontario CED for the drug committee. So as you can see here, we have some work to do to coordinate all these aspects. The OTEC decision making per se look at several criteria in talk about health technology. You look at about the clinical benefit for some of those outcomes. You also look at the consistency for the social and the ethical value, also the value for money and the feasibility for adaptation. Bearing in mind, if you read this OTEC decision-making model, lacking in there is innovation. So it's not really driving innovation per se, what we've been talking, is instead of just looking at the cost effectiveness. So we do want to assess part of the innovation. And indeed, Ontario did invest in the innovation. The Ministry of the Research and Innovation established about a few years back, did invest into those areas, and there's another branch that are continuing working together to push for the innovation. If you look at Alberta, their system is more or less similar to Ontario. They incorporate 5 domains, and they incorporate innovation right into the assessment. They have their health gain, service delivery, strategic feeding, innovation, and the financial, and they have the criteria of the 12 criteria, similar to other centers. If you look around the world compared to Canada, the UK group, the NICE have the multi-criteria decision-making as well. They have a little template you can log on, and you can do the assessment comparing to current technology versus the new comparator, and the more or less similar domain that you can see here regarding a wide range of criteria, about 10 to 12 criteria. In the Scandinavian country, the same thing, similar a tool for us to advise for technology advancement, diffusion into the public. If you look at that, really, how do we support some of those organizations to diffuse the evidence-informed making in the patient? Very important when they assess the capacity of the local institution. You want to ensure the appropriate collaboration for the decision maker, both for the stakeholder, the physician, the hospital, and maybe the industry as well. And you also ensure there's adequate, independent of conflict of interest. That's one of the major aspects with all these conflict of interest regulation coming in North America and also in Canada now. This has to be very clean and transparent in dealing with those aspects. Using a systemic and transparent method, that's the HTA locally that we've been driving at. You need to be explicit, you've been transparent, and just be comprehensive in delivering the evidence. And then you ensure there's adequate capacity and basically a cycle of the knowledge translation cycle and action flow. Despite that, you look at, we spend so much money in the basic science, in the clinical science, in the knowledge-based generation. You talk about a whole host of synthesis or knowledge generation. We developed so many clinical science publications, applicable and basic science. And how many of those two value of challenge we kept saying, how is that, why not diffuse in the patient practice or into your community in aspect? And we always have this gap, this knowledge translation gap in decision making, despite adequate guideline and consensus and the monitor or the test. It's because a lot of things are locally determined. As you can see, the earlier graph I show you, the in coordination sometime in all this knowledge and the evidence and the practice. A lot of those are local priority, even in our setting in Ontario, regional priority. Local operational, public health need, alternative. We have need the trained personnel, human resources is an issue to deal with some of this knowledge transfer, infrastructure and resources, and different budget impact as well as the HTA and also all the other HTA agents. So bring back to our own high-cost, high-tech area. Acute care hospital is indeed a very expensive area that we spend our healthcare dollar. And that's why back about nearly about 8 years ago, we set up the acute care setting, the EPICOR, for the clinical, peri-op clinical outcome research group is now head by Dr. Janet Martin in our department, looking at the peri-op area, medicine, surgery, and the critical care area. So what we aim to do is to create a timely, contextualized evidence, which Dr. Janet Martin will tell you later this afternoon in her presentation regarding the value, some of those aspects. So I'm just going to very briefly give you a overview. And the Know4Go framework that she has developed is tremendously useful and implementation for those outcomes. And basically what she have defined for us, not only you have to look at the evidence synthesis on the risk and benefit. We all do the cost effectiveness with all the costs, and you do need to look at what we call the slipper that she have coined it, and then you have to do the opportunity cost to, if you're going to implement something alternative, what other alternative you're going to give up in your other budget in the hospital. You're going to do more PCI for coronary revascularization. How many more cardiac surgical procedures you're going to let go in order for you to fund those projects, as we all don't have an unlimited dollar to do all the procedures that we all want to do. So this is her slipper assessment. I won't go into detail, but it's really encapsulates a very comprehensive aspect of this is only the beginning after you generate the evidence, is to know of the resource aspect, the social aspect, the legal, ethical aspect, environmental infrastructure, political aspect. Sometimes it's political trump some of those decisions in some of the cancer medication as we see in the newspaper these days. Entrepreneurial innovation values, research opportunity, and stickiness. If you implement some technology or technique into the acute care, how fast you can take it back out after you set up a system. So with that in mind, we also look at why physician cannot diffuse. Despite all this nice system, we are not only the only one having the local HTA. more and more of the other institutions start to pick up the pace. You look at, after we have all these scientists and clinician scientists, we look at the evidence, look at the need, ask the right clinical question, we did the research, we synthesize all those evidence, distill out the best evidence, the 7A of diffusion, which is you need the healthcare profession and your institution to have the awareness, to have the accept the new evidence or the technology or the technique. They have to be applicable. They have to able to able to deliver those. They're able to add on those actions, and they have to be agreed on. And then they have to adhere and maintain and sustain the change. This is basically a change management that you have to do in healthcare delivery. And you look at some of those. Every single 7A as being described by Paul Glacier from Oxford. Now he's back to Australia from evidence-based world. Looking at, even if you have a 20% leakage, you can see there's a tremendous diffusion gap for uptake at the end of any solid evidence that you even generate, either be technology or technique. So skill set, et cetera, for those to pick it up. So why physicians say no? I mean, this is the top 10 list of Letterman, you can say. It's either they don't pay attention. I mean, they either claim they're too busy, they pay no attention. Some of those because they don't like those data, they attack the data and say because this is my competitor doing the research that they don't like, they attack the data, or they maintain absolute confidence in their own practice. Sometimes we say when people continue their own practice, clinical practice for so many years, they basically perpetuate their practice, outdated practice with increasing confidence. So they maintain absolute confidence that what they're doing 25 years ago is still very, very good and very beneficial to patient. They follow the pack, they defer to the expert, they want to delay, they bring in the lawyer, they being challenged, they say, I don't want to change my practice, with my impact on my medical legal, if I'm going to use that technique or technology or procedures. They blame the patient, it's not me, they don't want to take the medication or they don't want this uptake, and they're going to say, well, you change, not me, right? I mean, this is not, I don't need to change my practice, and you have to change your practice. The poor rank and simply refuse to make change. Not helping the physician, though, is also in our literatures. We have all this controversial research. Despite everybody with good intention do high quality research, there are sometimes evidence change. If you look at some of this data, this is summarized by in JAMA. Prime example is the hormone therapy a few decades ago. And now the hormone therapy initially good intention for treatment and found out to be actually detrimental. The same thing for our medication in our cardiac world. One of the blood clotting drugs in cardiac surgery, protein, has been off the market a few years ago. That's because after the new evidence come out, a much proper trial for assessment for randomized control trial actually done in Canada, the BAR trial, and now that particular medication is off the market. And the other aspect as well for poise and all the other things. So when you look at technology, we always have a very, very fast pace of a peak of inflated expectation. This is new, this is improved, that must be good. So everybody jump into the bandwagon. And they very rapidly, they got into what we call a trough of disillusion, especially in the technology and procedure world. And then somewhere they're going to find their path and plateau off and hopefully maintain and sustain the productivity. I'm going to give you one very quick example in the surgical world, which I work in the operating theater. This is a few years back on one of those atrial arrhythmia, irregular heartbeat in patients who have heart disease, particularly valve surgery. And after surgery, even if the surgeon replace the valve and repair the valve, the patient will still have irregular heartbeat, have a high risk for stroke and all these other problems. So the medical device company devised this microwave for the ablation to try to resolve the arrhythmia after surgery. And you can see the early clinical report are tremendous, positive, successful. So everybody, the whole market dominated with different way to, microwave, radio frequency, heating, infrared. So all kind of thing going to use. Numerous companies develop to do this technology for atrial fibrillation. And there's no dose response until further study in a few years back. Later, demonstrate actually we're doing more harm to patient. Until then, the whole scenario, the huge, high expectation, a big disillusion, and then actually that has been disappeared from the technology device. So indeed, there's a lot of up and down and change. So assessment and continuous feedback loop is very important. So you look at some of these guidelines also, why physicians not comply to guideline. This is just recently published by Chakotay in JAMA in 2009. You look at the ACC, American Heart Association, a lot of cardiac science come up from there. And this is more or less a guideline for cardiac practice. Only 11% of those guideline recommendation, and they are only supported by level A evidence, randomized control, only 11% that we are practicing day in, day out in the patient. And 48% are level C, which is opinion. So we all done by, and that's why physicians have a lot of practice barrier. So why physicians sometimes don't follow practice guideline? It's basically, it was defined as about 3 categories, but I'm going to add the 4th one in there too. Knowledge. Physicians need, sometimes they don't want to change or cannot uptake the technology or device or procedures because they lack of familiarity with the knowledge. They're not able to get access to the knowledge. They're bombarded with multiple information in there. Numerous literature is coming out. There's conflicting literatures. They don't know how to synthesize the literature. They're busy clinicians. They are not aware, they have no time, and they don't get access to high-quality guideline. And then the attitude, some of those lack of agreement, we saw the top 10 over there, lack of outcome expectation, and the lack of motivation. They don't want to change, they're too busy. Or behavior, patient factor as well, and environmental factor. The institution is not geared up for the change. They don't have resources for them to change. And also the reimbursement incentive for them, they don't have no interest to change. In our technical and surgical world, in the acute care setting, skill is also another barrier for change. Sometimes it's not being highlighted. What we sometimes see is the lack of the technical training opportunity. The surgeon sometimes, after a whole decade or more than 2 decades of practice, if a new procedure comes out, very difficult for them to go back and retrain and redo the procedure. Sometimes that's not how they do it, and become difficult for learning curve and how we can facilitate that. So you talk about technology assessment. Either be you don't want to be some of the the innovator, early adapter, and become majority and late. So you want where you should fit into those curves. So all physicians sort of sit around the whole curve like that. You talk about surgical innovation, the stakes are very high because it's a very highly expensive aspect. And you look at some of the technology and the procedures and the device, more than the drugs. A cardiologist, they can say we do a randomized control trial, 10,000 patients, they send out the aspect, the intervention is the drugs. For a procedure and a technology and technique, the operator is at stake too. So they're at high risk. They become one of the failure for concern for some of the innovation. And so they are also in a unique conflict of interest because they are the one who recruit the patient. They are the one to have confidence in the technology, and also they are the one got consent the patient into doing those. And the development process, as I mentioned earlier, and the learning curve for them, and the early adapter as well. So how do we introduce innovation and technology in the current new era, particularly in the surgical and the peri-op anesthesia world? Define your innovation, open address, efficacy, and safety. Very important to set up a task force or HTA locally with a multidisciplinary approach and have the institution and organization support. You need to have the precautionary principle. First, do no harm. Very important for all of us to adhere to. Well-designed feasibility trial and well-designed efficacy and safety trial. And then informed consent, very important for nowadays. So managing the learning curve for technology in the acute care hospital setting, we need to give them the tools to review the process, alternative the procedures, give them the options, give them the facility to train and to make sure that a infrastructure and resources for them to track the result, and also to kill some curve, which is the learning curve. Take, for example, one of these I use 2 centers, Center A, Center B. regarding, let's say, on heart transplantation, 30-day mortality. If they're going to set up a new procedure or program for heart transplantation, these are the the best acceptance for mortality, and these are the worst acceptance in your mortality. These two lines, this is a low acceptance, this is maximum acceptance for mortality. And center A actually is perform excellently. And center B, you can see that they are actually approaching very high mortality. So those patients are not being well served for heart transplantation. So you need a tool to evaluate and critically appraise when you diffuse technology or technique into your systems. So it's important to have the clinical training center. So how do we do that? In London, where we have the C-Star doing some of this technology assessment for training and the cycle. This is one of the view from the C-Star looking at one of the cardiac surgeon doing some of the innovative simulation for 3D reconstruction of a heart valve. So when is a procedure ready to disseminate? So when you have all those, you don't want to widely distribute or adopt those until the evidence of the efficacy and safety. There's so many examples out there that we are actually doing harm to patients. Assume that the innovator has to define their own learning curve first, and make sure that the people going to disseminate those, have the simulation training, have this QSUM curve, the QSUM curve developed, make sure that they can track some of their performance even after the diffusion. You have to have a proper HTA setting in your own institution, multidisciplinary, and make sure it's transparent and comprehensive. And develop training program for competency and guideline for new procedures when you're moving forward. So in summarizing, you want to diffuse, look at all different levels for health technology. The decision maker are the knowledge management skill. The healthcare system, you need to have the financial incentive, both for the innovator, for the decision group, and the partner with the industry and the government to develop the true innovative approach for healthcare. The healthcare organization need to build the infrastructure, coordinate the infrastructure. We as physicians need to have to make sure the barrier for knowledge, attitude, behavior, and the skill are fully developed and fully embraced in HT, the transfusion. The patient compliance is very important. So we need a local contextualization for health technology, for anything that you want to do. It has to be transparent. Institutional collaboration is important with the right incentive alignment. Doesn't mean that you always have to give positive incentive. Sometimes you have to shift incentive, even collaborative incentive with physicians. Instead of losing their budget if they're going to change their practice, how can we incentivize them to change practice but share some of those reward? Technology, we have beating heart surgery. I didn't go into those. They're still in a debate. They are difficult in uptake because you need a new skill set for the surgeon to learn. Technical skill versus cognitive skill is totally different thing for technology diffusion because in the surgical world, we have the technical skill and the cognitive skill together. So you need training, learning, and also the equipment. And MD, as a physician, we need to champion some of the good causes for patient care advancement and true innovation for the benefit of our patient. So thank you very much for your attention.